Welcome to A&A Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. Today, we'll talk about the role of neurostimulation in the treatment of medically refractory epilepsy. Neurostimulators are a set of devices that deliver electrical impulses to the nervous system and actually change neural networks over time. These devices are effective at reducing seizure frequency, and they also collect useful long-term data about an individual patient's seizure pattern. Joining us today to discuss neurostimulation and neuromodulation in epilepsy is Dr. Vikram Rao. Dr. Rao is a leader in this field, an epileptologist and associate professor of neurology at the UCSF Weill Institute for Neurosciences. Dr. Rao was interviewed by A&A producer Dr. Rohit Das, epileptologist at UT Southwestern Medical Center. Here's Rohit.
Welcome, Dr. Rao. Thank you so much for joining us on this A&A Investigates podcast to talk about neuromodulation in epilepsy.
Thanks for having me. It's my pleasure.
I'd like to start by asking you briefly to describe the current FDA-approved neurostimulation and neuromodulation devices.
Yes, we have 3 FDA-approved devices for treatment of epilepsy currently. The oldest one, the one that was approved in 1997, is called the vagus nerve stimulator, or VNS. And then the more recent devices are the responsive neurostimulation system, which is called RNS, and a thalamic deep brain stimulator called DBS. And these 3 devices that have become available over the years are really quite different from one another. They all have a common goal of reducing seizures, of course, but they do that through very distinct strategies. VNS is a device that is considered an open loop device. And what open loop means is that it essentially delivers stimulation, electrical stimulation, in an on-off cyclical pattern without dependence on a specific trigger. That device is a battery that's implanted in the chest and is connected to a lead wire that encircles the left vagus nerve in the neck and applies electrical pulses to that nerve that travel to the brain and reduce seizures in that way. RNS is a completely different strategy. RNS is actually implanted in the skull, and it has 2 lead wires that are placed inside the brain at the site or sites where seizures have been found to arise from. And RNS is considered a closed loop device. And what that means is that it's not on-off all day. It actually delivers therapy in an on-demand fashion, meaning in response to detections of abnormal patterns of activity that can herald imminent seizures. And then finally, DBS is a distinct strategy yet. In a way, it's a hybrid, if you will, of VNS and RNS. It is an open loop device like VNS, so it delivers stimulation in a scheduled intermittent fashion. But it's an intracranial device, so it connects to lead wires that go into the brain to a deep nucleus, the thalamus. Stimulating the thalamus then can reduce seizures as a result.
When you see patients with epilepsy, at what point would you consider these devices?
When we see people who have epilepsy, the first line treatment is always anti-seizure medications. And we certainly have a lot of those. We have over 30 different anti-seizure medications available. About 2/3 of people will have their seizures controlled completely with one or some combination of those medications. But that means that 1/3 of people do not have seizures controlled with medications alone. And that group of individuals that we refer to as having drug-resistant, also called medically refractory epilepsy, usually undergo a evaluation to determine if they're candidates for surgery. And surgery can come in several forms, but the concept is that if you can identify the seizure-producing brain tissue very precisely, and if that tissue is safe to remove through a surgical procedure, then that might be an intervention that could significantly reduce seizures and sometimes even cure seizures. But some patients are not candidates for surgery, either because their seizures come from a part of brain that is not safe to remove, or because their seizures come from more than one spot, and it's often not feasible to do surgery to remove brain tissue in more than one location. And so it's that group of individuals who are not only drug resistant, but are not ideal candidates for surgery, who we start thinking about for neurostimulation devices.
What do we know about the outcomes of neuromodulation in patients with epilepsy?
Well, we've learned a lot. As I mentioned, VNS was the first neurostimulation device for epilepsy, and that's now been around for almost 25 years. So we have a lot of experience, and we learned some things along the way. One thing that we've learned that is actually true of all three approved devices is that these are palliative therapies, meaning that a minority of patients become truly seizure-free with any of these therapies. And that's an important thing to know at the beginning. They can help, but they don't often cure. The second thing is to know that efficacy of these devices, meaning their ability to reduce seizures, actually improves over time. In the long-term trials of RNS and DBS, for example, outcomes improved over the course of many years. And by 9 or 10 years, patients had a median reduction in seizure frequency of about 75%. So that means that if somebody was having, let's say, 8 seizures a month on average before getting one of those devices, then over the years, if they were an average responder, we might expect them to go down to 2 seizures per month. We have less prospective data on long-term trials of VNS, but the data that we do have suggests that efficacy improves over time as well. It's important to know that there actually are no head-to-head trials of these devices, so we can't really comment on their relative efficacy because they've never been compared directly in a controlled clinical trial. And then the last point I would make is that there's a growing awareness in the field that if you try one device and you don't have the outcome that you had hoped for, that doesn't necessarily imply that other devices will not work. And so failure of one does not necessarily predict failure of other devices. It's reasonable to try other things. And perhaps that relates to the very different ways in which these devices are thought to work.
The fact that the efficacy of these devices improves with time is truly fascinating. What is the process of implanting these devices? How invasive are they? And what are their risks?
All of these devices are invasive. They are implanted in the body, which requires a surgical procedure, and therefore all of them are associated with risks of pain, infection, and bleeding. The nature of the surgery that's required to implant the devices is different for each one. VNS is a completely extracranial, meaning outside of the brain, implantation. As I said, the device is placed in the chest, the lead wires are placed in the neck, and so there's no need for brain surgery with VNS. RNS and DBS, by contrast, are both intracranial devices, so brain surgery is required for implantation of the lead wires in the brain. With RNS, the battery and the electronics are actually housed in a device that sits in the skull. DBS, the neurostimulator itself, is placed in the chest, analogous to VNS. So there are risks associated with these surgical procedures. There are also some risks associated with the therapy themselves. So with VNS, for example, because it stimulates the left vagus nerve, which sends nerve branches to the vocal cords, there is a risk of change of voice, cough, or hoarseness. Some people have worsening of things like obstructive sleep apnea. With RNS, because it's a cranially implanted device, there is a risk of headache or pain at the implantation site. The stimulation with RNS is rarely perceptible, but some individuals will be able to perceive the stimulation. That is really an uncommon scenario and one that can be mitigated by changing the way the device is programmed. And then with DBS, there's a risk of paresthesias, meaning abnormal sensations. There's some concern from the trials that there's a chance of memory deficit or worsening of mood. Those concerns have largely been allayed by long-term studies where these were specifically tested. But there are at least some studies suggesting that sleep can be disrupted with DBS just as it can with VNS. So these devices are considered, it's important to note, quite safe. Even the implantation surgeries themselves have risks that are in the 2 to 3% range of things like infection and bleeding. But they're not 0% risks, and the therapies themselves have important considerations.
Thank you for talking about the risks and the benefits of these devices. Your work suggests that repeated localized cortical stimulation can actually change the brain's functional networks or circuits. Could you tell us a little bit more about that?
Yes. There were 2 observations that we and others have made over the years. And the first is that if you take a therapy like RNS, for example, typically patients receive actually hundreds or thousands of stimulation pulses per day, which sounds like a lot, though these are very brief pulses and that only amounts to a few minutes of stimulations per day. But even so, thousands of stimulations are delivered per day in response to detections, mostly of activity that is seen in between seizures. Most of that stimulation is occurring in between seizures. Patients don't typically have thousands of seizures per day. So that's an interesting observation. And the second observation is one that we talked about already, which is that we know that efficacy improves over long periods of time. RNS was conceived as a seizure stopper, if you will, something that's going to detect an imminent seizure, it's going to stimulate the brain, and it's going to stop the seizure in its tracks, perhaps akin to a cardiac defibrillator. And that might be some component of its mechanism of action. But it's probably not the whole story, because if it was just a seizure stopper, you might expect to realize the full clinical benefit of that therapy all at once, as soon as the device goes in. And that's not usually what we see. So those two observations suggested that there might be more long-term changes in the brain that are affected by these therapies that actually serve to reduce the likelihood of seizures over long periods of time. And we term that neuromodulatory effects that serve to sort of restructure the brain network in a way that it's less apt to make seizures over time. And so our question was, how does that work? How might that work? And can we have evidence of that, direct evidence? And recently, we've actually taken advantage of the fact that the RNS device stores recordings of brain activity over long periods of time. And looking at those recordings, what we found is that there are actually changes in the way that brain networks are organized in response to therapy that unfold over long periods of time. We can see that things like functional connectivity, the way that different populations of cells in the brain talk to one another, that those change, they reorganize in a plastic way in response to therapy. And interestingly, critically, the people whose brains do that the best are the people who respond to the therapy the best. So what differentiates, say, a super responder, somebody who has a terrific outcome with RNS, from somebody who doesn't have the best outcome with RNS, is actually their ability to reorganize brain networks. And that difference emerges very soon, often within the first year of therapy.
I really appreciate your differentiating neuromodulation from neurostimulation. A super important question for practicing neurologists and epileptologists. Can these devices be used to predict when seizures will occur?
Well, the short answer, I think, is we think so. The unpredictability of seizures is really one of the most disabling features of epilepsy. Patients tell us this when we ask them. We ask them, what's the worst thing about having epilepsy? And of course, there's a lot of answers. But in some surveys, the number one answer is simply the fact that seizures seem to occur at random. And that leaves people in a state of looming uncertainty. And uncertainty is stressful, and stress is disabling. So we wondered whether we could do something by leveraging this really unprecedented data set that we have access to, these long-term recordings of brain activity made with devices like RNS. Could we leverage them to learn something about what factors influence the timing of seizures? And it turns out that those chronic recordings have taught us a lot. They've taught us that there are cycles of brain activity that unfold over timescales that are longer than what was previously known. We have known that brain activity demonstrates so-called circadian variation. We've known that for a long time. That means fluctuation about the course of a day. But we've more recently learned that there are actually also multi-day cycles of brain activity that span 1 week, 2 weeks, maybe a month. And whatever cycle a given person may have in their brain activity is relatively stable for them, but could be different than what another person's cycles are. What's really interesting, though, is that these cycles are not just a curiosity. They're actually critically important for determining seizure timing, because it turns out that seizures tend to occur preferentially at certain phases of those cycles. So we reasoned that if we could characterize a given person's cycles and we could identify the high-risk periods of those cycles, then maybe we could extrapolate forward in time and sort of anticipate over some future horizon moments when they might be more likely to have seizures and moments when they would be less likely to have seizures. We've actually demonstrated the feasibility of that approach in a retrospective data set. So we had a 10-year data set from the RNS clinical trials. We were able to build models that were trained on the first half of that data and then forecasted, if you will, estimated the likelihood of a seizure in the subsequent data that the model had not seen. And we showed that for a number of individuals, we could reliably forecast seizures better than chance up to about 3 days in advance. That, of course, is not perfect, but we think that this forecasting approach could really help people in the same way that weather forecasts are helpful. It's helpful to know in advance if there's a high chance of rain on a given day. You can do something differently. You can pack an umbrella, for example, and we hope that some of our ongoing prospective forecasting efforts might one day help people with epilepsy pack umbrellas, meaning take more medicine when they're at higher risk for having seizures, maybe alert friends and family when the chance of a seizure is high. That's really the dream.
Dr. Rao, are there other advantages of neuromodulation and neurostimulation?
One of the most eye-opening aspects for me as a clinician using these devices over the years has been that although they're all intended as therapeutic devices meant to reduce seizures, they actually all provide different forms of information about what's happening in the brain or what's happening, for example, with the heart rate, which is detected by VNS. And it turns out that the ability to observe those data over long periods of time is very helpful for such a dynamic disorder as epilepsy. And it turns out that you can learn a lot with a wide temporal lens that allows you to glimpse that dynamism. So, for example, with RNS, we have been able to find evidence of the dynamics of seizures. For example, people who have seizures that come from both sides of the brain, we've been able to look and estimate how many seizures come from each side. What is the true ratio? Is it 50-50? Is it more skewed than that? That's something that's hard to do with a short timescale study. So it's been very eye-opening to see things like medication responses. When I start a new medication in a patient, I can look at trends in detections of abnormal activity made by a device and use that information to help me gauge whether this medicine is likely to be helpful for this individual or not. Those are things we've never really been able to do in neurology. Another example is if a patient calls and describes a symptom that they're having, for example, a spell of dizziness. It's not uncommon that we get asked, could that be a seizure? And normally we're left really with just our clinical hunch, and we do the best we can. In patients with these devices, we're often able to look at the brain activity recorded at the time when the patient had those symptoms and really try and assess in a more objective way whether there was a seizure at that time or not. This is really a kind of a brave new world of neurology that there hasn't been ways to do this in the past. And so that not only makes it even more fun to do clinical epilepsy, but I think it really serves our patients very well. Another point that's related to the therapeutic function of neurostimulation devices is that they may benefit people with epilepsy in ways beyond reducing seizures. For example, there's early data that some patients can experience modest improvements in memory or in language function, depending on the location of where the stimulation is applied. I think it's early days for us to really understand how that might actually play out. But the use of these devices is now expanding in a research context to other indications, even beyond epilepsy, like mood disorders and other neuropsychiatric phenomena. So I think the field of neurostimulation, really, people are appreciating more and more that delivering electrical stimulation to the brain to modulate circuit dysfunction in some adaptive way is really an appealing strategy that certainly helps people with epilepsy, but may help people with many other medical conditions as well.
A final question for today. What neuromodulatory techniques are coming down the pike? What are some of the exciting directions that you see from future research?
Well, there's so much. I really view what we have now as the tip of the iceberg. There are a lot of things in development, including improvements to existing devices. For example, development of new stimulation paradigms for VNS, development of new devices for DBS that have the ability to sense brain activity, the development potentially of RNS devices that have more than 2 lead wires, allowing you to sample broader areas of the brain. But there are also completely new technologies that are in various stages of development. And among them are things like external trigeminal nerve stimulation. That is a therapy that's applied through bilateral adhesive skin electrodes that stimulate branches of the trigeminal nerve above the eye and deliver electrical therapy to the brain to reduce seizures over time. Transcranial electrical stimulation, which involves subgaleal, meaning under the scalp, electrode arrays that can deliver electrical stimulation to the brain in a less invasive way than an intracranial device. And then even devices that are focused on magnetic pulses, transcranial magnetic stimulation. This has some challenges related to the sort of size of the hardware that's needed to deliver the magnetic pulses, but this is also a non-invasive way to potentially modulate brain activity. So I really view this as a tremendously exciting field filled with a lot of optimism. I'd love to think that someday we have devices and a mechanistic understanding of how they work that allow us to treat epilepsy completely non-invasively and in a faster way than is possible now. We may look back one day and wonder that it was such early days when we had things like epilepsy surgery and 30 some odd medicines. And so I'm a believer in devices, and I'm just so thrilled to be a part of this rapidly evolving field.
Thank you, Dr. Rao, for this fascinating discussion on both neuromodulation and neurostimulation in epilepsy.
Oh, well, thank you. It was my pleasure.
That was Dr. Vikram Rao, epileptologist and associate professor of neurology at the UCSF Weill Institute for Neurosciences, interviewed by Dr. Rohit Das, epileptologist at UT Southwestern Medical Center. To listen to past episodes of ANA Investigates or to suggest an idea for a future podcast, visit myana.org. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Dr. Megan Ritchie. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.